The first thing, administering subcutaneous injections. Know what type of needle size you use, know the angle, know what angle to give it when somebody is very heavy or obese, when they're very skinny, and the conventional administration, which is, the conventional is how many degrees, guys?
45.
45. 45 is the conventional. If they're heavy, then it's gonna be 90 degrees. When it comes to subcutaneous injections, what type of medications do we administer subcutaneously? Heparin, what else? Insulin, yeah. What else? Lovenox or enoxaparin. Good. I'll talk about that later. All right, primary versus secondary hypertension. Primary has no specific cause. You cannot pinpoint it. But secondary, you can attribute the hypertension to a
disease
specific
process.
medical disorder or disease process. Yes. Remember that primary is also known as essential. Number 3, function of the lymphatic system. So the lymphatic system serves as a protective mechanism. It's part of your immune system. It transports lymph and lymphocytes. It allows for the transportation of white blood cells so you can fight off infections. The lymph nodes serve as cleaning stations that filter blood, and through the process of phagocytosis, they remove any cell debris, any microorganisms that might cause infection and things like that. That's what the lymphatic system does. The lymphatic system is also responsible for the movement of fluids. So if you lose particular lymph nodes, for example, if a woman is diagnosed with breast cancer and she has a radical mastectomy, which is the removal of the breast tissue, they usually remove the lymph nodes that are associated with the cancer. At that point, you cannot do blood pressures on that arm because the lymphatic system is not capable of bringing that fluid back to where it's supposed to be after that cuff squeezes the tissues. On the same note, you cannot do any checks on the finger or any type of invasive procedures on that extremity because you don't have the lymphatic vessels to transport the lymphocytes and fight off the infection. Does that make sense, guys?
Yes.
Okay. I'm talking fast because you guys are recording this, so it's easier for me. Identifying complete versus incomplete doctor's orders. That's something you guys are going to have to look up, but essentially the doctor's order will have what?
Meds,
Doctor's
route,
medication.
day,
Make
times.
sure you guys know the date, time, and all that is cool, but make sure you guys can identify a complete order. So it's got to have the parameters: the drug, the dosage, the scheduling, okay, BID, PRN, whatever the case is. Make sure it has all those elements in order for you guys to say that yes, this is a complete doctor's order. Function of the thymus, it deals with the immune system, primarily when you're a child. It atrophies after you hit puberty, and it atrophies more so as you age. So the function of the thymus, it produces thymosin. That's a hormone that helps you with your immune system. Also, your T cells mature in your thymus. Thymus is located in the thoracic cavity. Make sure you guys know that. Function and location of the spleen. So the spleen works as a reservoir for blood, about 500 mLs of blood on deck in case you have a bleed. You won't go into hypovolemic shock right away. That's why the book talks about a human being able to tolerate a blood loss of up to 500 mLs because you have the spleen. Once you lose more than that, the book says once you lose up to a liter or 1,000 mLs, that's when you may develop the signs and symptoms of hypovolemic shock. The spleen is also responsible for filtering out old or worn out RBCs. It produces lymphocytes, and it's also responsible for phagocytosis. It's located in the left upper quadrant of the stomach, of the abdomen, and it drains into the liver. I'm sure you guys know all those things. Administering blood and parameters that must be followed. So, when you administer blood, you have to make sure that you get the cross type and match. Make sure it matches. Make sure the same blood type. Make sure if the patient that's receiving the blood is Rh negative, it doesn't matter what type of blood type you have, but if the patient receiving the blood is Rh negative, the blood that they're receiving cannot be Rh positive. You guys follow? But if the patient is positive, it doesn't matter what they receive, because if it's negative, it doesn't matter, there's nothing there. And if it's positive, well then, high five, they both have the same Rh factor. Does that make sense, guys? Let me see, where am I? You have 30 minutes to administer the blood products once you remove them from the refrigerator, usually the lab. You need, according to different hospitals have different policies, but the book says 30 minutes. Another thing you guys should know is that whenever you're administering blood, You should verify the cross type and match and the donor ID and all that with another licensed professional. For the first hour, you should assess the vital signs every 15 minutes. For the next hour, you should assess it every 30 minutes, and then every hour after that. Blood is transfused not less than an hour, right, guys?
Right, not less than that.
It's usually administered in 3 to 4 hours. You have to look out for any signs of rejection, any blood transfusion reactions, which it can be something as simple as like a rash. Your body starts developing like anaphylactic reaction. It could be hemolysis, which means that you probably got the wrong antigen. The wrong Rh factor, and your immune system starts destroying that receiving blood. You're gonna have jaundice because of that, because you're destroying all the blood cells that have bilirubin inside. Regardless as to what's causing the blood reaction, the blood administration reaction, what do, guys?
Stop it.
You
Stop it.
And then after you stop it, you flush with normal saline, and
Return
then
it.
you can return all the tubing supplies back to the lab so they can analyze it, and you should provide them also with a UA, a urine analysis, at least 10 mLs of urine, so they can analyze it and see if there's anything else going on. Does that make sense, folks? Did I forget anything?
Return unused blood too.
Yeah, the whole thing, yeah. Alright. Rheumatic fever happens when an upper respiratory infection caused by staph or strep is not fully cured with the antibiotics, usually because of a lack of adherence to the medical regimen. They don't take it for the 10 days that they're supposed to. The staph or strep usually goes to one or two areas. It goes to the kidneys or to the heart. Right now we're talking about the heart. It causes endocarditis or valve issues, and the patient has valvular disease after that, valve disease. That's rheumatic fever. Blood thinners and their corresponding lab values and antidotes. So I'm gonna let you guys look for the specifics, but I'll give you guys the general statements. Blood thinners, we have heparin, and the lab value associated with heparin is partial thromboplastin time, which is PTT. The antidote for heparin is protamine sulfate. Your other anticoagulant is Coumadin or warfarin. The lab value associated with that is prothrombin time and the international normalized ratio, or your PT-INR. The INR should be less than 3.0, usually 2 to 3, but less than 3.0. And for your PT and PTT, whatever the control is, the therapeutic value should be 1.5 to 2.5 times that control. You guys remember that? Okay. The antidote for Coumadin is vitamin K. There's going to be quite a few dosage calculations, folks. D over H, drop factor, mLs per hour. So they'll tell you the doctor ordered 1,500 mLs to give over 8 hours. How many mLs per hour will you give? Things like that. Number 11, identifying normal sinus rhythm. So if I show you guys on this little, right here, what is this? It's PQRST, but what type of rhythm is this called? Guys, this is, what wave is that?
P, Q, R, S, T.
That's what I said, right? For a normal sinus rhythm, the P wave also always has to precede the QRS, and the T wave always is after the QRS. Do they meet those parameters?
Yes.
Yeah, so what type of rhythm is this?
Normal.
Normal
NSR.
sinus rhythm, right? What's this?
AFib.
Yeah, AFib, right? Because you cannot identify a definitive P wave.
Yeah.
The QRS is still intact. That means it's not a ventricular issue, it's an atrial issue. And if it looks like that, it's probably AFib, right, folks? What's this one? No. Huh? McDonald's, right? What happens when you eat too much McDonald's? You have VTAC, ventricular tachycardia. It looks like the McDonald's arches. Okay, usually 180 to 200 beats per minute. What about
Regulation, atrial, AFib.
if it's an atrial issue? Will you be able to see the ventricles?
Yes.
Yes. Do you see the QRS right now?
No.
So what type of issue is so powerful that it overtakes?
Crisis.
Okay, yeah, but what part of the heart Ventricular, so this is VFib, ventricular fibrillation. What's this?
Systole.
Asystole, right? Asystole is no pulse, okay?
Non-shockable.
Yeah, you can't shock asystole. You can only shock your V-fibs. All right, let's go with, oh, and also remember, P wave represents atrial depolarization. The QRS represents ventricular depolarization. The T wave represents ventricular repolarization. You guys recall that? Okay, make sure you guys review it. Make sure you guys also understand that when I'm talking about depolarization and repolarization,
Rest.
I'm just talking about the electrical conduction. It doesn't mean that it represents the actual heartbeat, because you have that phenomenon called a pulseless electrical activity. You guys recall that?
Yes.
Where the patient has some degree of rhythm, but there's no pulse, so you have to do CPR. That's why you always, no matter what the EKG machine says, you always assess the patient. Something as simple as a heart rate would do. The electrical activity always precedes the actual contraction, folks. Make sure you guys know that. Listen to what I'm saying. The electrical conduction, the P wave, let's say. What's the P wave known as? The atrial.
Depolarization.
So this comes before what? Atrial depolarization. The electrical activity happens before what?
No.
Yes, the actual contraction of the atria. You guys follow? So if I say the patient's ventricles just contracted, what preceded that contraction? No. If I say did I say atrias?
We said ventricle.
So if the ventricles contract, if the physical contraction occurs of the ventricles, what electrical conduction precedes that particular contraction? The QRS. What I'm trying to say is this, guys. Every rhythm that you have, every electrical impulse that you have, this whole complex, right? So this is a love dub, right? Right after your P wave exerts its effect, what part of the heart is gonna be contracting? No, guys. What does a P wave represent? Atrial depolarization. So once the shock, I say shock because the electrical surge that happens at the atrias, the electrical representation is the P wave, right? Then what should happen after? The atrias will contract. Does that make sense? So that's what I'm trying to get at. Each complex precedes the actual physical contraction of that particular representation of the heart. So P wave precedes atrial contraction, or atrial depolarization precedes the atrius contracting. Ventricular depolarization precedes a ventricular contraction. You guys follow? Okay. Cardiac EKG findings for, that's not the one either. Etiology of a heart murmur. The blood is flowing
Flooding.
turbulently somewhere else, so there's an extra sound in your lub dub. That's what a heart murmur, the etiology is, okay? EKG findings for angina and MI. Well, say that one more time.
12.
What's 12? Differentiate between heparin and Coumadin. Oh, okay, thank you. Heparin, folks, is given for relatively short term compared to your Coumadin, right? So if I'm a patient and I'm spending a month at the hospital because I had a heart attack, right? While I'm at the hospital, they're gonna give me what medication? Heparin. Before I leave, they're gonna start me on what medication? Coumadin, and they're gonna wait for my PT and INR to be in their therapeutic value before they discontinue the heparin. Does that make sense, folks? So we're transitioning one medication to another. We're switching it because we like to give Coumadin for long periods of time versus the heparin, because you have to give injections and all that stuff. 13, right? 13 says clinical manifestations of left. So what are the manifestations when it comes to left-sided heart failure, folks?
Lungs.
Lungs. All your symptoms deal with lungs, whether it's paroxysmal nocturnal dyspnea, hemoptysis, crackles of the lungs, pulmonary edema. It's left lung issues. Your right-sided failure deals with the body, right? Whether it's CVP, central venous pressure that increases because of the superior vena cava and all the other central veins, whether it's dependent edema, hepatomegaly, splenomegaly, thank you. It's all right side, so make sure you guys review those topics. Clinical manifestations of fluid volume overload. The fluid is excessive, so there's a wide variety of manifestations, but usually it's weight gain, edema somewhere in the body. That's the concept. You guys follow? 15, interpretation of EKG, PQRS, what they represent. We discussed that already. Did I miss something? Okay. We talked about etiology of murmur, right? EKG findings for angina and MI. So when you have angina, it's just ischemia. The tissue's not dead yet. So with ischemia, you'll have PQRS, and then the ST segment is depressed. When you have an MI, there's actual infarction going on. The tissue actually dies off. That's PQRS. I'm sorry, let me take that back. Got excited. PQRS, and sometimes it doesn't. It's going to be an ST segment elevation. You guys follow?
Too long of a pause?
Ischemia is ST depression and MI is.
ST elevation. What was
Okay.
that? Oh.
No, okay.
And for those, we discussed them during, if you guys get the PowerPoints or your lectures from the day that we cover, we cover all the stuff, guys, so I don't know if you guys go back, but most of you guys had those PowerPoints, so just go back to them and it'll be there.
Mr. Hernandez,
Yes,
you
ma'am.
said angina and ischemia.
Angina and ischemia is the same thing.
Interchangeable.
Yes, sorry, yeah. Alright, KG findings. Cardiac enzymes, we have a few. We have lactate dehydrogenase, LDH. We have CKMB, myocardial bound. We have CKMM, which is not specific to the heart. And then we have our favorite, which is troponin. So troponin is what we like. We like troponin because it's elevated for up to 2 weeks. We like troponin because it starts elevating within 3 hours of the onset of chest pain. We like CKMB because it's specific to the heart, but it only lasts 3 days, folks. 72 hours. Make sure you guys revisit your peak times and your onset times for those particular cardiac enzymes. Focus on troponin and CKMB. ABG interpretation. If I do an ABG, what's the normal pH? Oh man, you guys got a 7.35 to 7.45. The normal CO2, 35 to 45, and your HCO3?
22 to 28.
22 to 26, even though the book says 28, 26. If my pH is 7.14, my CO2 is 61, and my HCO3 is 24, what is this condition called? How do we know it's respiratory acidosis? Because the first thing we do is we look at the pH. The pH is supposed to be 7.35 to 7.45. Anything above this value is basic, which is alkaline. Anything below this is acidic. So this is higher or lower than 7.35.
Lower.
So we know it's what?
Acid.
So with acidosis, we can already eliminate the other two that say alkalosis if that's what the other options are, right? And CO2 and HCO3, what organ controls CO2?
Respiratory.
Or respiratory, right? And then what organ controls the HCO3? The kidneys, right? These are the,
Metabolic.
and that's metabolic. So because, and we know that CO2 represents
Acid.
acid, HCO3 represents base. Well, we have a lot of CO2, which means we have a lot of what? And it matches the pH. Okay, there's no
Respiratory.
compensation that we're gonna be working on the exam, but if you guys could understand, I know I did it fast because we talked about it before, but hopefully that kind of clears up things up for you guys. Alright. Cardiac diet. Low sodium, high fiber, good. Low sodium, high fiber, low
Fat.
cholesterol.
Low fat.
No alcohol, maybe a little, no alcohol, no smoking, all that stuff. Okay. Cigarettes, thank you. No smoking cigarettes. What's wrong with this guy? Interventions to prevent venous stasis, what do?
Ted Hose.
We start with least invasive first, right? Ambulation, Ambulation first, and then if that patient's on bed rest, and now we start talking about the TED hose. How do you measure it? No, no,
The TED
hose.
hose.
Yeah, where should they go up to? Below the knee. So you measure it from the ankle to the popliteal area, right? Okay. Manifestations of DVT. Well, if someone has a deep vein thrombosis, the calf will be red, hot. The patient will have pain when they dorsiflex, as they point their toes towards their face. Those are signs of DVT. What type of blood values are going to be elevated? Starts with a D. Do you guys remember?
D-dimer.
D dimer will be elevated. That means there's excessive coagulation. I just remembered something. Talk about that. Nothing to do with you guys. Stable versus unstable angina. Stable, you can predict it. Unstable, you cannot. You're getting pissed off for some reason, or just you don't know. You could be sitting down, and unstable angina. That's when you'll feel the pain. How do you treat angina, folks? Nitroglycerin. How many? What's the desired route of administration?
3 times within 5 minutes.
Sublingual. You can give it a max of 3 times with 5 minutes in between. Okay, good.
Wait, you said the unstable is?
Stable, you can predict it. Like if I'm gonna go out for a walk, I know I'm gonna get angina, so I can take my nitroglycerin ahead of time. Things like that. Unstable, it happens with no physical exertion, and sometimes your emotional state can actually cause an anginal attack.
Even at rest.
Even at rest. If you're just sitting down and you're watching football, whatever you guys watch. RBCs, folks, you need to know the values. So RBCs are 4 to 6 million. Hemoglobin 12 to 18. Hematocrit 37 to 52%. Platelets 150,000 to 400,000. White blood cells 5,000 to 10,000. And what happens when the levels are too high? Well, if your RBCs are too high, you're gonna probably clot because you have polycythemia, right? Same thing with hemoglobin, hematocrit. Platelets are too high, you're gonna clot. White blood cells are too high, you have an infection. RBCs, hemoglobin, and hematocrit is too low, you're gonna have anemia, you're gonna be cold, activity intolerance. Platelets are low, you're gonna have bleeding tendencies. White blood cells are low, you're gonna be immunosuppressed, so you're gonna be at risk for infections. And if your immune system is so low, your white blood cells are so low, your body won't even be able to activate the inflammatory mechanism, and you won't even be able to tell that there's an infection anywhere. So those are the issues with the blood cells. Average stroke volume, we talked about that. Make sure you guys read about it, okay, guys? Define cardiac output and stroke volume. It's what you add, okay? The formula that we discussed. Rationale for vagal stimulation. What does the vagal stimulation do? It decreases your heart rate. Yeah. Sympathetic nervous system is fight or flight. It increases vital signs. Parasympathetic is essentially your vagal response. Rest and digest. It decreases vital signs. Please make sure you guys know the anatomy of the heart, where the different AV valves, semilunar valves, the chambers. Make sure you guys know the flow of the heart through the flow of the blood through the heart. For the adult, the coronary arteries perfuse the myocardium. When you have angina or an MI, those are the blood vessels that are being affected. Cardiac catheterization, the biggest issue is neurovascular assessment, folks. Your CMS before and after the procedure. Also, after the procedure, keep the legs straight, keep the patient on bed rest for several hours to prevent any bleeding. Meaning the head of the bed should also stay no more than 30 degrees. Where am I? Oh, applying antibiotic stock, we talked about it. ABC concepts when assessing or intervening. When you're assessing a patient, folks, ABCs is always your priority. What is tetralogy of Fallot?
It's bad.
There's 4 conditions, make sure you guys know what they are. It's pulmonary stenosis, overriding aorta, ventricular septal defect, and hypertrophy of the right ventricle, or ventricular hypertrophy. Anemia in infants.
It's hard to tell.
When?
6 months.
For 6 months, why?
They have a surplus from.
Yeah, they have the maternal reserve, so it's difficult to assess that. Labs to assess for clients with hemophilia, clotting factors.
8 and 9.
8 and 9 is correct. Foods high in iron, folic acid, and B12. Both B12, folks, is gonna be animal products. And your iron and folic acid is gonna be
Green leafy.
green leafy, guys. Make sure you guys can differentiate the two. I'm only asking you for one of them. Make sure you guys know all of them. We talked about CK and B troponin peak and duration times. Make sure you guys know those, okay? Relationship with depolarization and actual contraction. What did we talk about? That the depolarization precedes the physical contraction, right? Foods, high sources of potassium, potatoes, bananas, apricots, things like that. Clients at risk for orthostatic hypotension, what age group? Older, because they're probably on diuretics or some type of antihypertensive. Good. Let's see. Loading dosages. Loading dosages is just a word that we use when we're gonna give a medication with a predetermined desired value. That's what a loading dosage is. Describe dietary approaches to stop hypertension. A DASH diet. That's what a dietary approach is to stopping hypertension, by the way. That's what it stands for. Low sodium, low
I know
cholesterol
what it feels
diets.
like.
Lifestyle modifications for hypertension and cardiac disease. Stop smoking cigarettes, exercise, eat good food. Lose weight. Indications of bleeding, well, your vital signs will change. Also, you'll have pallor. You may have LOC changes. Your urine output may also be depleted. It just depends on how well developed the bleeding is. Etiology of hemophilia, it's an X-linked chromosomal issue where the mom passes it to the dad and we lack clotting factors 8 and 9, right? Polycythemia vera, you have excessive blood cells, which is gonna cause hypercoagulability, which includes stroke, heart attack, all that stuff. Education to family about sickle cell anemia. Well, first of all, the trait is when you carry the gene that can cause it, but you don't actually have the disease. And the disease is when both of your parents had the actual trait, or one of them had the actual disease, and the other one had the trait, and now you actually have the disease. When somebody has sickle cell anemia, keep them hydrated, decrease stress, give them their vaccines. Pain is a big issue with sickle cell anemia clients, folks, so make sure you guys address that. You're gonna give opioids and things of that nature, that's appropriate. A Coombs test assesses for bilirubin levels, it assesses for the RH factor also. Digoxin is a medication we give for heart failure. Make sure you monitor the potassium levels. People that take digoxin, they're probably also taking Lasix, which depletes potassium. Digoxin toxicity, what is that?
Visual.
Nausea, vomiting, and you'll have visual disturbances, usually yellow pigmentations in the visual field, not in the sclera, okay, folks? What do you give when someone has digoxin toxicity? Digibine or immune fab, right? And then nitroglycerin, we discussed that already. How do you position the client before giving nitroglycerin?
Sitting down.
At least sitting down, preferably laying flat. Yeah. The patient will have a tingly sensation in their under their tongue when you give them the medication. Store the vials of the nitroglycerin in a dark, cool area. Replace the medication every 3 months. Yes, ma'am?
And they lay down because of the change in blood pressure.
It drops the blood pressure. It's
Drastic change.
yeah. No potassium depleting and sparing diuretics. So your furosemide, your hydrochlorothiazide, those are your potassium depleting. Your spironolactone, aldactone, those are your potassium sparing. Okay. Know what can happen to the potassium levels when you're taking each of them. Initiating bleeding and neutropenic precautions. If the patient has bleeding tendencies, we provide soft bristle toothbrushes. We want to make sure that we give a high fiber diet. And if somebody has neutropenic precautions, no fresh fruits, no fresh flowers, high risk for infection. I think we're done, guys. What time is it?
Time to go.